Thank you, Alexis. And I'm going to be sharing with you the rationale for the development of gene therapy in particular in sickle cell disease. This is a disease that we've known about for quite some time now, over a century. It's in fact the first molecular disease, so it's deserving of a molecular cure. Well, it was described in 1949 by Linus Pauling, who went on to get a Nobel Prize for this work. And it's a simple substitution at position 6 of the beta-globin chain. So it's the same genetic spelling in everyone, at least with sickle cell disease. There are some other variants. And this results in an abnormal hemoglobin that's prone to polymerization upon deoxygenation. And this obstructs the circulation and causes all sorts of problems: severe anemia, frequent pain, end organ damage, and early mortality. And it's a rare disease in the U.S., affecting only about 100,000, but not in the world. There are many millions affected in sub-Saharan Africa, as this arose as an evolutionary adaptation to malaria. And we really only have a handful of therapies at the moment, and these are largely supportive. And we heard a little bit earlier from Stacey Arnold about sickle cell disease as an example in her talk, and it's a disease that affects really all organ systems, as shown here, most devastating of which is the brain when strokes occur in young children. But as I said, really every organ is affected, and this results in morbidity and early mortality. And when you look at patients for whom we have newborn screening and know the entire set, lifespan is about 40 years, even in the modern era. So this is a really devastating disorder with lots of morbidity and early mortality. And there is a cure for sickle cell disease, and we've known about this for a very long time. In fact, this is the first patient whom I met at the St. Jude's conference where she was advocating for transplantation. She had acute myeloid leukemia, underwent a transplant for leukemia, which was refractory chemotherapy, when she was 8 years old, and she was cured of that leukemia. She also had sickle cell disease, and she was cured of sickle cell disease as well. So this really prompted interest in this type of therapy for sickle cell disease. And transplants are pretty simple. They replace the seeds of the blood. And in the case of sickle cell disease, if you replace the bone marrow stem cells with new stem cells from someone else, you should correct the red cells. But we've also been working at not replacing them with somebody else's stem cells, but taking the patient's own stem cells and trying to fix them. So that's where we are here. We know already allogeneic transplantation works. There have been big studies showing this. I'll show you a little bit of data, but we're also working on ways to take patient cells, add a correctly spelled copy of the gene, or even use newer technologies like CRISPR to edit the cells and put them back corrected. Eventually, we hope to be able to do this in vivo without a transplant and all the morbidity associated with it, but we're not there yet. So this just shows a retrospective cohort review of the last 10 years of allogeneic transplantation for sickle cell disease. So we chose to cut this off just before publication so we would have adequate follow-up. And you can see event-free and overall survival is really quite good, especially for the blue line here with an HLA-matched sibling. But with other donor sources, half-matched, HLA-matched unrelated, or mismatched unrelated, survival and event-free survival are quite good. And for any other disease, this would be really terrific. But in a non-malignant disease, we want these curves to be much closer to 100%. Additionally, the highest event-free survival was for those less than or equal to 12 years of age, again with an HLA-matched sibling graft. So we know if we start early, we do better. Our experience allowed us to figure out how much do we need to fix this disease. We had over 100 patients in our own center, more than 60 that we had long-term follow-up. And unfortunately, we had 3 patients who, despite really robust engraftment initially, had a decline in the measurement of donor in their marrow and peripheral blood. And when they hit 20% donor, they had recurrent symptoms. And we put together a mathematical model and determined that it's just that the red cells live longer when they're normal that allows us to get all the way down to 20%. So these are the data for the 3 patients in red, and this is the mathematical model put together by Courtney Fitzhugh and Stephan Cordes that are just superimposable on the line that we observe. So as long as you have a normal red cell coming in either from a donor or from a genetically modified graft, you should be able to fix the disease. So we've moved through animal models and into the human now. This has been quite a difficult course because usually when we get to the large animal model, we find it's not ready for human application and wind up going back to the drawing board. And we've done this over the years, now more than 2 decades, to both maximize benefit and minimize risk. And we're now in phase 1/2 clinical trials. And gene therapy has really now come of age. This is a review by my colleague Cindy Dunbar showing all of the advances that have happened in the 2000s, such that now we have late 2014, the initiation of gene therapy trials for the hemoglobinopathies, including sickle cell disease. And how do we do this? Well, we make viral vectors that we've got of their infectious features, and we've put in a copy of the correctly spelled gene, and we use this to move that genetic material into the hematopoietic stem cell. And if we're efficient enough, will result in a normal hemoglobin production coming from these cells that we've infused. And the first success with this was using lentiviral vectors that were based on HIV-1, really because HIV can get into stem cells. And we did this in the non-human primate and showed that we could reach the levels needed. 20% here is only half the graft, giving us more than 30%. We did this with globin-specific vectors and had higher than 20%. And then we launched a clinical trial testing this in humans once we'd reached that milestone. And this has undergone some changes in evolution over this time period to Group C now, where we've optimized the pre-collection transfusion and the hematopoietic stem cell source and the way we put this gene into those stem cells, such that now we have patients who have about 40 to 50% of their hemoglobin coming from vector, and this has normalized their total hemoglobin. You can see this one group of 3 patients out at 30 months with about half of their hemoglobin coming from vector and with a normal total hemoglobin as compared to their baseline of 8.9. And these markers of red cell destruction in the peripheral blood have normalized. If we look at red cells, nearly all of them now in these hashed stacks here have the transferred hemoglobin contributing. And this is one of the most important slides, is that the vaso-occlusive events, so each of these dots meaning a pain event requiring a medical intervention, such as a hospitalization for narcotic therapy, have gone completely away after 6 months. So when we had these data, we were faced with the question, how does this stack up to allogeneic transplant? You've heard about allogeneic transplantation already, and there are multiple publications showing that sickle cell disease is cured by an allo transplant, so you would expect that everything just gets better. But in fact, there were no data for us to compare. So we had to go back and get those data from our own transplant patients. So Alexis Leonard in my group did that, and here you can see the number of vaso-occlusive events in blue in the 2 years before transplant, with some patients with nearly 50 events requiring hospitalization over those 2 years. And in the first year after transplant in yellow, you can see that many of these adult patients are still having painful events that bring them back to the hospital. But after the second year, these are quite rare. So again, like the gene therapy experience, the pain and the hospitalizations are going completely away. And Ash put together a panel to look at recommendations for transplantation, and this is for allogeneic transplantation. And we found that there's just not that much in the literature for us to base doing a transplant, except again to say that we know they work and that sickle cell disease goes away. One of the important things was, would the risk for stroke go away? And in fact, it does. It's almost zero after a transplant, the risk of a subsequent stroke. But it's not that the stroke that the patient had will get better with the transplant. I've just shown you data on pain. It does go away. Acute chest syndrome also goes away. We had some other questions like, who should get a transplant? When should they get it? How should you transplant them? And what should be the source? And these were even more difficult to answer with the data that are present in the literature. So I can cut a long story short by saying, my task of telling you how gene therapy is going to roll out in terms of reversibility of disabilities is still not clear. We need long-term studies, both of allogeneic transplantation recipients and of autologous gene therapy transplant recipients before we can know what things get better. But I've told you brain stabilizes, no new strokes. Lung and heart, they seem to improve, at least from our own experience. Measures of heart and lung function improve. Kidney function does not. So whatever damage they've accumulated will persist and, in fact, may worsen just around the transplant. Splenic function in kids may improve, but in adults, there's nothing left of the spleen to improve. Bones and joints that have been destroyed by this awful disease also don't get better post-transplantation. So a number of the problems that patients have with sickle cell disease, they will continue to have, even if they're cured of their disease. So my final thoughts, gene therapy is now demonstrating efficacy in sickle cell disease or many other diseases that can be approached in this way. We see a reduction in pain similar to that achieved with allogeneic transplantation. So we're hopeful that the other improvements that we've begun to see with allogeneic transplantation will also be seen with the gene therapy approach. Unfortunately, much of the accumulated end organ damage persists after curative approaches, so that will have to be kept in mind. And finally, when these approaches have been proven curative, we need to move them earlier in the course of this disease prior to organ damage, and that should improve outcomes. So I'm going to stop there and pass it to David for the next talk.